Today my presentation is really in response to questions that I've received from several members in our community who really wanted to get some insights on, how does RUNX1 work in other parts of the body, not just the blood, and can that help us connect to the way in which we are experiencing some of those signs and symptoms that you have in your lives. I'm just needing to move these pictures. No, forgive me 1 second because I can't. Can we drag that up? Or you can close it. Yeah. There we go. Perfect. So my goal with this presentation is really to walk you through what's currently understood about RUNX1 biology. As I said, not just in the blood, but across the entire body. And that being said, though, I want to make very clear that everything I say is not meant to be medical advice. I am not a physician. I'm not a medical doctor. And a lot of what I'm going to share with you is coming from the lab, from research, and not found in the clinic, not really demonstrated in humans. So let that be well understood. But hopefully this will still be valuable. So let me start by grounding on how to interpret everything you're about to hear. So what I'm sharing today really comes from two main sources. One is the clinical data from RUNX1 FPD, and that's really driven from the NIH, and then some of the data we've collected through the Patient Data Hub, where we've learned from all of you about what you're experiencing. But the other is, as I just mentioned, laboratory research on RUNX1 biology. And that second type of information is the largest part of this talk. So it's from a lot of research in the lab, and it's not necessarily actually from scientists that were here at this meeting. So the scientists that were here at this meeting are very much focused on how RUNX1 works in the blood system. So the work that I'm going to show you is from medical literature search that I did, looking to see where is RUNX1 playing a role in other tissues, and again, how that might connect. So it's looking at different cell models, it's looking at different animal systems. I even have some studies that I'll point to that explain how RUNX1 protein might be working in different diseases. And so you might be asking, well, why are we even looking at how RUNX1 functions in a lab, for example? Why would that even matter? And it turns out that the gene RUNX1 is highly conserved. So what does that mean? It essentially means that the way that it works across organisms, from a fruit fly all the way through a mouse to a human, works pretty similarly. So we can actually learn from these different kinds of model systems. All right, so I want you to think as I go through this talk, I want you to think about signals, not conclusions. We're connecting dots. We're not proving cause and effect. But again, I think at the same time, emerging patterns are worth paying attention to. But certainly don't want to drive any kind of alarm here. And then finally, I would say most importantly, there's a lot of individual variation. And so what applies broadly may not apply to you, and vice versa. So now, do we feel grounded in what the goals are here? Okay. All right, how do I move here? Just this one? Okay. So I feel you've probably discussed this now quite a bit, but RUNX1 is more than just a platelet gene. It plays a central role in the blood cell system, and most importantly in blood stem cells, which I know you've probably also heard about now multiple times. These are cells that are essentially like factories, producing all the different blood cell types, including platelets, of course. And because RUNX1 is so critical for platelet biology, it's also the reason we see bleeding symptoms. But beyond platelets, RUNX1 also governs immune cells, which are part of the blood system as well, both adaptive immune cells like T cells and B cells, as well as innate immune cells like neutrophils. And when these immune cells get dysregulated, they can produce a lot of pro-inflammatory cytokines. And these cytokines, which maybe you've heard of some of these, like IL-6, TNF-alpha, IL-1, I'll come back to these in a little bit, they circulate through the bloodstream. And so from the very beginning, okay, RUNX1 functions within the blood system, and the blood reaches the entire body, right? And so what's flowing and streaming through the blood, it can touch all these other organs and it can affect how those organs function. But there's more. There's a second important concept here, and that is that RUNX1 is not only active in blood cells, it's also expressed directly in many other different tissues throughout the body. For example, it's expressed in the skin, it's expressed in the gut, it's expressed in the nervous system. So this gives us a way, like two ways in which RUNX1 can play a role through the immune system, the blood, but also in the actual tissues themselves. So I'm going to go through different organ systems, and we're going to talk about what do we know and what can we do about that. So let's start with dental health. From a biological perspective, in mice, so now we're learning, and forgive me, I actually didn't take the time to put all of the citations on every single slide, but I will share with anyone all of the citations that I used to pull this information. In fact, I might just put a whole bunch of citations at the end of the deck, and we can share it. So in mice, we know that RUNX1 plays a role in epithelial and tooth development. That means in the embryo. And parts of the mouth, especially gums and enamel of the teeth, are derived from these epithelial cells. And RUNX1 plays a role in how these cells develop and function. So, and it's important to emphasize that in these models, they're disrupting RUNX1 completely. So there's no RUNX1 at all. So what I'm describing is like a complete deletion. In us, in individuals, and you guys, it's more of a half, like 50%, or to simplify it. So when in mouse models, when RUNX1 is disrupted, researchers are seeing defects in enamel and structural abnormalities in teeth. And in humans, we don't have that direct data, but we do know from the RUNX1 Patient Data Hub that some individuals in our community have actually reported tooth enamel issues, have reported, of course, history of bleeding, gums, and that makes sense because of the platelet phenotype, of course, too, gingivitis, and a few have actually mentioned tooth malformations. So it's quite possible there might be something there in terms of how RUNX1 is functioning when those epithelial cells were being turned on during development. The other piece is that chronic inflammation, which is driven, again, by our immune system, may increase the risk of periodontal disease, so like gingivitis. So it's really important to really recognize that we've got a system here, your oral cavity, that could be affected by RUNX1 through development, through bleeding, or through inflammation. So they're all intersecting. The good news is with dental care, there's lots of things you can do. There's lots of practical steps you can take. Regular dental visits are probably a really good idea for all of us, but sometimes maybe more frequent visits are more important in this setting. And then also a high quality toothpaste, one that has pH balance, especially if enamel quality might not be there. And I'm not suggesting, maybe most people don't even have this, but it's possible, and we did see a signal in the RUNX1 Patient Data Hub. And then I would say the most important thing is discussing with your dentist that you do have RUNX1 FPD, you have this bleeding risk, so that they're aware, especially when they're, if you need to have any procedures done. Okay, skin, okay. About 50% of individuals with RUNX1 FPD report eczema or eczema-like symptoms. This is not coincidental. So RUNX1 is expressed in epithelial cells of the skin too. It helps regulate immune signaling pathways that control the skin barrier. And RUNX1 is a key protein in regulating epithelial stem cells within the hair follicle. So it promotes the activation of those stem cells, and it is essential for the growth of the hair follicle. And interestingly, there's a very recent paper that just came out this year suggesting that hair follicles may actually represent a central hub for immune surveillance in the skin. So if RUNX1 is playing a role in the epithelial cells within that hair follicle, we also know that RUNX1 is playing a role in the immune cells. And if these hair follicles are immune sensing hubs, you can imagine that if there's any kind of disruption, that the skin might be more sensitive. So it's important to recognize that if the barrier is disrupted, it allows irritants to come in, allergens can enter more easily. That can trigger an immune response, inflammation, and so all of that connects again with symptoms like eczema, sensitivity to any kind of harsh fragrance, etc. So what can you do? This is also one of those areas where daily habits can make a really big difference. Moisturizing regularly, especially with thick fragrance-free creams, can really help restore the skin barrier. Avoid triggers like harsh soaps or fragrances. Extreme temperatures can also reduce any kind of flare. Track patterns. So just noticing when flares happen and what might have triggered them can be incredibly helpful and information you want to bring to your doctor. And regarding any potential hair loss, we do have some individuals in our community that have experienced alopecia. There's some interesting mouse data suggesting that RUNX1 might play a role in hair homeostasis. It's unclear exactly how, but I think it's another really interesting insight that there might be some connections here. But what's important is that there's effective treatments for these dermatologic issues. So it's important to just talk to your doctor and get help if you're having issues. All right, GI symptoms. So what do we know about the gastrointestinal system and RUNX1? It turns out that GI concerns are one of the strongest signals we see in RUNX1 FPD, and this is data coming from the natural history study, showing that about 80% of patients reported some kind of GI symptom. And that rate is actually not as high in the RUNX1 patient data hub. We have about 55%, but suffices to say it's more than in the general population. And some of the more common signs and symptoms are GERD at about 43%, constipation at about 40%, and dysphagia, which is essentially difficulty in swallowing, is at about 27%. So this isn't a subtle signal. This seems to be quite real. And so why might this be happening? Well, the gut is the largest immune organ in the body. So changes in immune signaling can lead to inflammation. And at the same time, RUNX1 appears to be playing a central role in the nerves that control the gut movement. So that also makes sense when people are struggling with constipation, because you need gut motility, gut movement to move things along. It's also active in cells that maintain the gut lining, so including those that produce mucus, which protects the gut. So when you put all this together, again, it might help explain symptoms like reflux, constipation, and any kind of discomfort. So what can you do about this? The most important thing is not restriction, but it's awareness. Knowing that there might be a connection here, and if you're challenged with any of these issues, keep a simple food diary, even for a couple of weeks, and you can start to reveal meaningful patterns. Regular meals and hydration can really support motility. It's also worth asking for a GI evaluation, especially if you're discussing symptoms and you want to talk about whether they might be related to higher levels of inflammation, or are they related to motility issues, because how you treat those would be different. And then ultimately working with a dietitian can also help avoid unnecessary dietary restriction. You want to have a good quality of life. So you want to make sure that you're optimizing your nutrition and you're living a comfortable, happy life, eating the foods you want to eat. So that gets to diet. It does, though, play an important role in inflammation. And so you do also want to make sure that you're thinking about getting certain kinds of foods in so that you can influence your gut microbiome. So your gut microbiome is really important because it does have an impact on inflammation and the cytokines that are produced as a result of the food you're taking in and as a result of the bacteria that you have living in your gut. So research so far shows, and maybe some of you got to see Urvi Shah speak at our webinar, and if you didn't, I highly recommend you hear her talk. It's on our YouTube channel. And in that talk, she essentially shows the data that supports and there's many, many studies that support this, but that fiber-rich, plant-forward diets are really associated with lower levels of inflammatory markers. And that said, though, there's not necessarily one size fits all diet. And what works for one person may not work for someone else. So again, tracking your response to different kinds of foods, I think it probably only takes a couple of weeks, and then building your own plan. All right, moving on to the respiratory system. So many patients report allergies, sinus issues, and airway sensitivity. RUNX1 plays a role in T cell regulation. So when that balance shifts, allergic inflammatory responses can increase. And at the same time, RUNX1's also expressed in the cells that line the airways. Those again are the epithelial cells. So RUNX1 is definitely playing a role in the epithelial cells in many different tissues. And in mouse models, when you completely delete RUNX1 in those airway cells in the epithelium, it actually drives inflammatory lung disease. So again, that's a very extreme situation because you're deleting RUNX1, but it gives us a signal that maybe there's more to a RUNX1 mutation just in the blood. So the other piece is that in some individuals, clinically, the NIH team has described seeing eosinophilia, that is a cell type, an innate immune cell type that is increased. And when that's increased, it's also been associated with conditions like asthma and eczema. So again, tying the blood system together with some of these issues. All right, so but what can we do about this? That's what I'm trying to, I hope I'm sharing with you that this isn't all doom and gloom and that there are ways to manage all of these things. So really the good news is you can manage this. You do want to take your allergies seriously if you have them or if your loved one has them, rather than just dismissing it and trying to power through. Try to reduce overall inflammation, try to figure out what your triggers are. Go get allergy testing. If you're allergic to dust, mold, pollen, there are ways to mitigate that. The other piece of allergies is it can really disrupt your sleep, and we all know how important sleep is. So if you can get your allergies under control, I highly encourage you to go see an allergist and get help. And then you can also even consider a sleep study if sleep is a problem. Okay. My kids have terrible allergies, so I know. I know what that's like. We've had to clear all the rugs from our house, and it's helped. Bones, what do we know? So joint pain and stiffness and flexible joints are also reported by individuals with RUNX1 FPD. We see that coming through in the RUNX1 patient data hub. RUNX1 plays an important role in bone biology. So it regulates the balance between these two cell types called osteoblasts and osteoclasts. Osteoblasts are the cells that build bone, and osteoclasts are the cells that resorb bone. And there's always this push and pull between those two cell types. In mouse models again, if you lose RUNX1 in the bone, what happens is the osteoclasts tend to get a favoring, and so you start to see breakdown of bone. And so you see lower bone density in those mice. And so it's clear that RUNX1 plays a role in bone biology, and whether that affects the joints in humans, unclear, but there's a link there. In addition, the inflammatory cytokines that we keep talking about that are produced by the immune cells, like IL-6 and TNF alpha, those can directly affect the joints. In fact, they're really critical drivers of diseases like rheumatoid arthritis, psoriatic arthritis, rheumatoid diseases. So it's not a surprise that if those levels are getting to be quite high, that they would affect those tissues. And then there's one more layer to consider, and that is that RUNX1 also plays a role in cartilage and connective tissue. So it helps regulate collagen production, it helps regulate the development of cartilage cells. So when again, in mouse models, when RUNX1 activity is reduced, it may actually affect how the joints are supported and how stable they are. And again, I want to emphasize, this hasn't been studied in humans, but these studies suggest that RUNX1, again, might be playing a role. And so the most important thing is, if you are feeling like this is something that you're struggling with, please go seek medical attention. It's really important, especially your joints, because if it is an inflammatory process, then there are treatments that there are ways to treat that. And or if it's mechanical, which is more like osteoarthritis, that's a different story, and there's different approaches to managing that as well. So, for example, like inflammatory pain tends to be worse in the morning and improves with movement, whereas mechanical pain tends to be worse at the end of activities or towards the end of the day. And so understanding these differences really can help guide treatment. And I think it's really reasonable to ask your doctor for a referral to rheumatology, or to ask about measuring inflammatory markers, again, if you feel you're struggling with, or you or your loved one is struggling with this kind of pain. Okay, cardiovascular. What do we know? So most of what we've discussed based on biology and emerging patterns, in cardiovascular disease, it's really an area where we have strong human evidence. So what we discussed before is biology in the lab, what we're understanding from mouse models. Here's where chronic inflammation is really recognized as a driver of heart disease. So it's not just an association. And there's been clinical trials showing that if you reduce inflammatory signals independent of cholesterol, you can actually lower the risk of heart attacks and stroke. So the same cytokines that we've been talking about that appear to be elevated in RUNX1, they are important in cardiovascular disease, like IL-6 and IL-1 beta. And so that's one important piece. The other is that clonal hematopoiesis, so we talked about these mutations that we acquire over time. All of us, general population as well, will acquire some of these, perhaps maybe just later in life. TET2 mutations are one that there's a little more concern about in the cardiovascular space. So TET2 mutations are known to drive inflammation in some of the downstream blood cells, and those blood cells are linked to promoting plaque and cardiovascular pathogenesis in the heart. So it really suggests that if you have it's important to share that if you have mutations, or if your loved one has mutations, share it with your cardiologist, so that they have the information they need and they can make decisions about management. So what can you do? I don't think that this is necessarily an immediate risk, and I don't think there's been a signal necessarily, right, David and Leah, in the NIH study that there's increased cardiovascular rates. But I think, like all of us, we should all be thinking about monitoring our blood pressure, cholesterol, exercising regularly, and then focusing on those anti-inflammatory lifestyle habits is really important. Okay, there's some good news in the cardiovascular space, and that is that there's some evidence that RUNX1 plays a role in how the heart heals after a cardiac event. So RUNX1 drives fibrosis, or scar formation, which is necessary for any kind of repair when there's an injury. But too much fibrosis can be harmful, because then the heart can get stiff. And so it appears that when you have RUNX1, if you have too much RUNX1, you might be driving too much fibrosis. And in the case of RUNX1 FPD, we might have maybe too little RUNX1, and so maybe fibrosis after a cardiac event wouldn't be an issue. All right, gynecology. Heavy menstrual bleeding is one of the most consistent findings in women with RUNX1 FPD. And it's clinically referred to as menorrhagia. You've probably heard that term. And so this is due to the platelet dysfunction, right? And it's important to recognize that platelet counts are not the only important thing. So even if a woman has relatively normal platelet counts with RUNX1 FPD, it's highly likely that those platelets aren't functioning properly. So if you're not managing heavy menstrual bleeding, that can lead to iron deficiency and anemia, and that really impacts quality of life. You're talking about fatigue, brain fog, lots of issues. But this is really treatable, really manageable. You can track your cycles, your symptoms. You can monitor your ferritin, which basically allows you to measure how much iron stores you have. And then there are medicines you can take. So there are treatments, which Leah mentioned earlier, tranexamic acid, but commonly what's used is hormonal therapies. And that you can work with your gynecologist to define what's the best option for you. Again, but you have to be an advocate and you have to kind of explain, right, what you have and what RUNX1 FPD causes and the importance. There's good news with pregnancy. So this is also thanks to the NIH team and a recent publication. Pregnancy is very much possible in women with RUNX1 FPD, and the outcomes are generally positive. The only really concern is the bleeding risk during delivery and postpartum. So the key is really all about planning, working with your hematologist, working with a high-risk OB, and having that coordination between your care team. All right, the nervous system. So RUNX1 is expressed in sensory neurons, which are responsible for pain signaling. And this is meant to really, this may mean it influences how you perceive pain. And we're not sure whether it goes one way or the other, whether you're more sensitive to pain or less sensitive to pain. That's unclear, but just want to briefly acknowledge that we've heard a lot of members in the community struggle with migraines, and we're starting to track that in our RUNX1 patient data hub. And there might be some connection here. So RUNX1 is playing not only in or pain sensing nerves, but those pain sensing nerves are then interacting with inflammation and the immune system in the brain. And it's understood in the migraine field that inflammation is a really huge component of migraines. So it's not unreasonable to connect the dots here with RUNX1 being involved in pain sensing nerves and inflammation. And so I guess I bring this up because I think if you are or your loved one is struggling with migraines, you have now some language to present this with your neurologist and say, there might be something here. Can we talk through this? And again, treatments, there are existing treatments, and it's important to get help. Okay, fatigue and brain fog. These are not uncommon either. This is also coming out in our RUNX1 patient data hub, and they are very real, but they're not usually caused by one thing, but by a combination of factors. And so we've talked about a lot of these now in this talk. There's inflammation, there's potential for anemia in women if they're not being managed effectively, sleep disruption because of allergies, and so all of that can contribute to fatigue and brain fog. And so this is more just a call to action to make sure that you do everything you can to try to help yourself by making sure that you aren't anemic and doing what you can to correct that, or using an anti-inflammatory diet to try to reduce inflammation, and then making sure that you're getting enough sleep to take care of yourself. So in the end, this is where everything comes together. You've got your skin, gut, joint, lungs, heart, etc. All these systems aren't really actually acting independently. They're connected right through the immune system. And all of these organ systems not only have immune cells and the bloodstream with cytokines coming into them, but you also have these organ tissues that are expressing RUNX1 for different reasons in different cell types. So the goal here is really about patient empowerment, giving you information and tools to better understand these patterns and hopefully feel more comfortable talking to any provider where you feel you need help in a certain area, and helping them understand that there's a lot of knowledge out there on what RUNX1 might be doing, and that it might be going beyond just the blood. And so I don't think you need to act on everything, and I hope that this feels like a session around education and awareness and not alarm. And I recognize that this is a lot to carry, and I recognize that living with a rare condition can often mean managing uncertainty and staying aware of your health all the time and thinking ahead in ways that most of us probably don't have to always be thinking ahead, and that's probably really exhausting. So I just want you to know I'm acknowledging that, and I understand if it's overwhelming. So final takeaways. I hope you feel that this brought awareness and not fear. I hope that it brings a little bit more understanding, maybe a little less uncertainty, and that it gives you, again, the ability to have conversations with your healthcare providers. And thank you for your attention. I'm happy to take questions, although I don't think I have any answers. This is just like...
Well, I'm bringing the microphone because the people online can't hear questions, and they love to hear what y'all are saying, if that's okay.
Katrin, I have a situation. My neurologist had cancer and quit. So I have to find a new neuro. Can I get the slide of migraine and inflammation?
And I'll give you all the citations too.
All right.
Yeah.
Perfect.
Absolutely.
Yeah, I may have forgotten to tell y'all that we are recording these sessions. So I can definitely share those afterwards if you missed any details and the slides. That was you, Amanda.
Maybe this might be a question related to what you said, but for the doctors in the room, that the role of inflammation has come up quite a bit over the last couple of days, and it's definitely something I've experienced. But whenever somebody does blood work to check for inflammation, the normal markers are not there.
Yeah.
So I was wondering, is that something that's normal, where you're like, just because it doesn't show on the test doesn't mean you don't have inflammation?
Yeah, it's because what they're testing is like CRP, right?
Yeah.
Right. Go ahead, David. I'm not. Why am I talking?
That's actually a really good question that we've been looking at. There are some people who have elevated CRP, excuse me, CRPs and ESRs, but usually it's the people who have the most severe inflammation. But we have plenty of people who have signs of inflammation that we're not seeing it in. And so we're trying to understand that. Dr. Agarwal presented some data. Well, they published it a couple years ago, where they were looking at some of the cytokines and other markers. That these are not tests that we usually do clinically, but they looked at some of that. Now that was done in bone marrow, and obviously we're not going to just do a bone marrow every time you feel a little bit achy. But we actually just got a grant at the NIH literally 2 weeks ago to kind of do a similar experiment, but we're going to look at the blood as well to try to really look for markers of inflammation. Whether or not that translates into something that we can really take into the clinic on a routine basis, I don't know. But at a very minimum, it'll maybe help us to really understand what's driving this inflammation, because it is subtle in some regards. In other words, it's not at all subtle. But if we can understand really what are the compounds that are circulating in the blood, what are the things, what are the signs, and maybe it's not a cytokine, maybe it's something else. We're trying to design the experiment to be as broad as possible, that maybe we can start finding new markers of this, and that we'll be able to follow those. And even better if we can target them and then maybe bring some of that inflammation down. But that is something we have noticed. The CRP and the ESR really are not a good test for that kind of things.
If I may, I just wanted to add that depending on like the different specialists that you would be talking to, they might use different tests to measure inflammation. So a rheumatologist might be testing other inflammatory markers. And so again, the point here is talk to your your doctors and say, here's what I'm learning. What tools do you have in your toolkit to measure inflammation?
Okay,
right?
yeah, that's kind of one of the follow-up question I had was, you were mentioning those specific cytokines, and I was like, is that something that we should be tested for if we're having the inflammation, but maybe not the normal markers or something like that?
I mean, I think like a rheumatologist, for example, just to pick on rheumatology, they care a lot about TNF. They care a lot about IL-6. So that's why I was kind of putting those in the slides, because those are very common inflammatory markers that they care about, because they actually have drugs to target those. And yeah, so I think those would be, and those are very high from Dr. Agarwal's work, which is what she saw both in the blood and in the bone marrow, but it was more extreme in the bone marrow.
I mean, you're probably not going to be able to answer my question, but lucky me, I have another rare genetic disorder that has some crossovers.
Oh, wow.
So I don't know if to do some of it that's RUNX1 related.
Right, how to uncouple.
Yeah,
Yeah.
exactly. I mean, but like I said, you guys probably wouldn't know that, but that's always my concern because I never know which is which. And I didn't know if maybe in the future there'd be a way to figure that out. Does that make sense?
Absolutely makes
Okay.
sense. Yeah, yeah, definitely. I mean, I think you're doing all the right things. You're participating and you're getting involved and you're learning as much as possible. And
Melissa has a question.
Speaking about inflammation, so you said there are drugs on the market for Enbrel, things of that nature, the biologics.
yep.
Is there any correlations between RUNX1 patients that do take these type of biologics? Any positive or negative effects for patients that have RUNX1 to take those? Kind of like, even if it's
Yeah, we had asked, and I think you presented, David, or was it Paul came back and presented that there were maybe like 3 individuals in our community that were on biologics,
Okay.
and there wasn't a signal that it was
no
good,
positive
bad,
or
or
negative
otherwise.
effects
Yeah,
for
yeah,
RUNX1
that's what I
patients?
remember. Does that ring true to you? Yeah.
Yeah, because it sounds like, inflammation has a lot to do with it. What about like, everybody, you're hearing all about these GLP-1 type medications. Is there anything in the thought about lowering the inflammation through those types of drugs for RUNX1 patients?
Well, Nancy Speck, who maybe you know about, she's the chair of our scientific advisory board and very much involved in our research community. She has plans to test a GLP-1 agonist in her mouse model for that, for questioning that aspect.
Awesome.
Yeah,
Thanks.
yeah.
I think we have a question online, and then I will promise I will let y'all take a break. And then yes, yoga is at 2.
In 5 minutes.
In 5 minutes. So, but I'll see if she can delay it. Let's see. Georgie asks, will those in the study receive the blood testing for new markers? Oh, I think this is what
Oh, you're
Dr.
grant.
Young.
It's very experimental at this point. If we do find something that we think is clinically actionable, we will share that either as part of the general community or if we found something specific. But the testing we're doing, I doubt, will be particularly useful, at least initially, from a person by person and clinical standpoint.
Oh, we've got, okay. Dr. Cunningham will roll us out with, no, that's just like our last session. We'll have her roll out thank you.
I'm sorry. I just wanted to add that for anyone who does want to do the imatinib study, then we do have clinically validated cytokines on there. They get sent to Mayo. And so what I'm trying to do with Anupriya from a research standpoint is to identify if there is a relationship between the clinically validated markers like IL-6, IL-8, TNF alpha, and what she's seeing, as well. So that's the most amazing thing about this community from a clinical and a research perspective, is the opportunity to do things like this, and will also correlate with Dr. Young's findings.
Yeah, thank you for that, Leah. It is really awesome. Everyone's working together.
Okay. And with that, Katrin will also be around if y'all have more questions for her.
Thank you.
Thank you so much, Katrin. That was really helpful.